everybody. Welcome to our latest town hall, and I think we have an excellent program today. We have some really good speakers. I think, Garland is our PA right now. I think, okay, that's Garland. If you need some assistance, try to get Garland's attention. And I hope we have another PA showing up, but I don't see her here. So we'll wait on that. We also have some students here who probably can help on some things as well. I think you all have the agenda, and a little different than usual. We're starting later, and we're serving our refreshments at the end, and we're going to be having some tacos along with a lot of other really good food. Woohoo! The bathrooms are down the hall to the, if you go right out the door, and they're should be accessible, but if you do need help with a PA or something, please let us know. I just want to let people know that we have CAN TV here today filming us right here. Say hello to Chris. And so the program will likely get put on CAN TV for later showing, so tell your friends to tune in. And we also have the cart, where if you want, you can actually get the cart on your phone and follow that as well as the sign language interpreter that we have. So we're trying to make it as accessible as possible. I also just want to mention that the lighting is the way it is because we had a request for no fluorescent lights for somebody. It's an accommodation that they cannot handle the fluorescent lights, but I think it'll work just fine. You can see the screen really well this way. We'll also have some question and answer periods, and make sure that when you ask a question that you speak into a mic. Otherwise, CAN TV cannot pick it up. So we'll have somebody carrying the mic, and it's really, really important that when you talk, you use a microphone. I'm going to now introduce Judy. Judy's my colleague here at Access Living. She's been an advocate for accessible transportation. She's been an advocate for women and girls' health care, and is I would call her an authority on durable medical equipment, one of the topics she's going to talk about today. And we're really happy to have Judy kick off our program. Thank you, everybody.
How's everybody doing today? So I want to see a show of hands. Who has never been to Access Living before? Raise your hand. Is it okay? Anyone else? Is this your first visit to Access Living? And all of the people who've been here before, raise your hand. Well, welcome. We just want to welcome newcomers, and we want to welcome everybody back. Tom and I have these town halls every quarter, and we use them as an opportunity to update the community on issues related to healthcare and disability. And every healthcare town hall is a little bit different. So after you come through this one, if you have suggestions for us on topics that you'd like us to cover in the future, just let Tom or me know. So today I'm going to start off just asking a few questions. We've had several calls from members of Access Living and consumers complaining about the fact that their food stamps have been cut. They've been reduced in value. Has anybody ever had that experience? 1, 2, 3, 4. Does anybody want to give me an idea of what's going on with your food stamps? 10. Do we have a microphone for someone to share? I mean, it just seems to me that there may be across-the-board cutting going on. I don't know. But anybody, could you, if you want to share your experience, give your name and a little story about what's going on.
Hi, my name is Cesar Mendez. And I have some bad news. My food stamps were indeed cut. I don't know if I'm using the right sign, but food stamps. Anyway, my food stamps were cut, and I really need food for my family. I'm really in need of this to be able to feed my family. My dad and I both are recipients of food stamps. And I want to get my Medicaid reinstated so that I can see my doctor whenever I need to. I need glasses, I need to have my hearing aids replaced and checked, and so I really need those services. And I'm really frustrated right now without that.
I understand, and it's particularly hard as the holidays are coming up. We don't want to be without our health supports or, being reduced in our food stamps. So did you know that you can appeal the process, that you can appeal to get your food stamps restored or increased? Do people know that? Has anyone been through the appeal process? Okay. We're going to take stories and then we'll talk about what we can do.
I would. Yeah. Oh, it's not funny. I would get $16 for food stamps.
You're getting 16?
No, I would.
He was getting 16.
Now I'm getting $15 for food stamps.
How much?
So you've been reduced from 16 to 15, is it?
Yeah.
Anyone else want to share their story? So we've got
My food stamps were reduced to $10.
from, do you remember?
30. I said they were reduced to $10. First it was $30. Before then I was getting $90, and then down through the years they've been reduced.
Right,
down
they
to
kind of
10.
gradually take
Yeah.
more and more money away every time,
Right.
which is pretty unacceptable.
Right.
And we don't have to stand
Can't
for
make
it.
contact with any of those workers to talk to them about the food stamps because they won't see you.
When you say they won't see you, can you tell me your experience?
Well, I went down to the aid office.
Right.
And I was trying to see, I don't know her name because she's never answered the phone for me or anything. And they told me I had to have an appointment.
Right.
I made an appointment with them, but the letter never came to tell me what day to come. And that was in 16.
Wow. So this is something that I think we need to look into more. The first thing we wanted to do was understand if there was a problem in terms of, we had gotten so many calls. We wanted to understand what the situation was. We've had some people that have had some success going in person, others who have called, the TTY, others have emailed, and some fax. But people tell me the most important advocacy is done in person. So Tom, maybe one of the things we got to find out is why people can't get appointments and how they get, if they're showing up.
Yeah. Well, we've done focus group on problems before. Maybe that's an idea.
Yeah.
I need to talk into the mic too.
Yeah.
One of the things we've done with problems, and Judy's covering various problems that we've been hearing about, but you need to get at the root of them. Sometimes a focus group can help, and we know people here are willing to tell their stories.
Yeah, I think what we're going to need to do is, are there other people that wanted to share their story about food stamps before we move into our next subjects?
Maybe it told me I get too much.
They told you what, Vincent?
I get SSDI. I get SSDI, and I wouldn't not that much. So that was my food stamp was cut.
Yeah, so what you're saying is they're telling you the reason your food stamps got cut is because you get SSDI.
Yeah.
I wanted to make a comment and ask
Edwin,
a question.
yeah?
Oh, it's Edwin, excuse me. I was receiving $16 for the food portion of my link card. All of a sudden, I'm getting $52.
So you're having the opposite experience?
Yes, so I want to ask, how do we know how this works? And another thing that I was told, and I want to find out if someone can verify it, is that now we no longer have caseworkers. When you go to the public aid office,
Right, you've just got to show up on your own or make your own appointment.
and then whoever's working will take care of your needs. It's not like it used to be where you would ask for your caseworker.
Right.
You know, Mary Williams. It doesn't work that way anymore.
No more
Is that true?
caseworkers. I don't know what other people's experiences are. What I'm trying to figure out is most people that I know that have had success have been there in person, but on the one hand, if you can't get an appointment and they're not verifying what time and you need an appointment, then there's an issue. Other people just show up. And does anybody else have an experience they want to share or
Yeah.
any solutions?
I have the mic here. I was going to say, my name's Scott. I was getting $66 a month when I got out of the nursing home 4 years ago. And then a year later, they just cut it to 16 with no explanation. Then they cut it to 0 after another year. Nothing in the mail, no explanation. So what I did, I took the whole 18-page application, I filled it out again like I'm starting from scratch. I don't even know if that's right or wrong.
So you started all over again, like as if you never had food stamps.
Yeah, because there was no explanation for anything, so I figured maybe I just start over and hope for the best. I
Well,
don't understand their methods for increasing, decreasing. It makes
Right.
no sense.
and did you, after you reapplied the second time, did you get food stamps?
I did it a couple weeks ago. I haven't heard from them
Oh,
yet.
you're still waiting.
Absolutely.
I've
yeah.
heard people use that strategy too. Anybody else have a story they want to share about food stamps or a solution they want to share?
Okay.
Your name, please?
My name is Jasmine Coates, and I get 100 and I used to get 194. Now I get 192. So they've cut, for whatever reason, they've cut my stamps from 194 down to 192. You have to go down there in person because of the simple fact of they don't answer the phone.
Right.
They will not answer the phone if you have a question for caseworkers.
The question I think we want to answer is, can you just show up and plan on spending all day there and they'll see you, or will they refuse to see you unless you have a pre-scheduled appointment?
No, well, what I do is I just show up there, but you have to show up with your ID.
Okay.
And then when you show up with your ID, they put your social security. They put your social security number into their computer screen, and then by them putting your social security number into the computer screen, once they do that, they will call. You have to sit and wait until they call your name.
Right. So it's kind of like when you go to the Social Security office, or even sometimes when you're in the jury pool, you just got to be prepared to spend all day there. But what you're saying is, if you show up and you're willing to spend the day there and you give your name, they'll get to you eventually.
Yeah, they'll get to you eventually, but they'll get to you eventually. They'll call your name, but then if you do not respond in a timely manner when they call your name, then you'll be waiting for a while before they call your name again.
Okay. Well, I think Tom's got a good idea that since we don't have time to spend all morning on food stamps, but we know we wanted to make sure that the calls we were getting were at least, we had a feeling the experience of people getting their food stamps cut was more than the several calls we were getting. And we wanted to try to brainstorm about solutions, particularly those things that have worked for people. Sounds like we've got an ongoing issue. Is there any one last comment we want to make before we move on to the other two issues?
Yes, I'd like to make it. Hello, my name is Jimmy Yarbrough. And yes, you do have to wait. Be prepared to be down there all day. You might not be, but be prepared for it. And another thing that you have to be is prepared. You have to know what you're going down there for. If they're cutting your stamps, you have to be able to show it, what they're doing. Maybe they made a mistake, and they will correct it right then and there. But you do have to be prepared when you go. So don't go down there saying something and you're not prepared. The one thing I learned in some of these classes coming here was to be prepared. So when you go down there, just be prepared.
Hi, my name is Donna K. Shaw, and I'm actually telling a story about a few of my friends. The three of us were talking, and they needed some help. So we went into the office, and there was no video phone to be able to speak to them. So we wrote back and forth on a piece of paper, and actually my friend and the folks at the office did. And I was kind of looking over their shoulder, and the person said, "I'm sorry, I'll give you the directions on what you need to do," and then they gave her some paperwork, and that's all they did. And so I asked, would it be possible for us to make an appointment and you have an interpreter available? And she just kind of made a face, and so I thought, I was just kind of testing out what their response would be, which unfortunately was that. And I said, would you be able to take her now and write back and forth? And they said, no, she can come back when we have time. And I said, okay. So, I didn't know what my friend was supposed to do. And I said, maybe if you come to Access Living, they can help you out. But she never showed up, so.
Well, thank you, Donna. It's a reminder that that's a civil rights violation. Whenever there's an interpreter requested, particular for a human service, you should be getting that accommodation. And they should be contacting our legal team, our civil rights team, if they're being asked for an interpreter and accommodation for disability and being denied that accommodation. So I think that's, I'm sorry to hear that, but the fact of the matter is they are required to supply an interpreter upon request.
Okay.
Okay, I think we had Chewy and then, right?
Yes,
Yeah,
Julie.
I got the mic. I was just
Okay.
waiting for. I was just waiting.
We're
for
talking
you.
about food stamps here, right?
Yeah. I heard the whole drift as I was coming in, and let me tell you guys my story, my situation here. I'm living on $17 a month worth of food stamps. Sure, I live on subsidized housing. My rent is like $230 a month, but that still doesn't. I mean, you can't make it on $17 a month, plus alone the other bills that I might have, like my phone or other necessities, doctor out of cost, So I went to Springfield a few months ago with Access Living, and I seen a couple of our friends who are state representatives. And I talked to them about my story about having to live on $17 a month.
Okay.
And so far, I haven't received no response, That doesn't justify the fact just because I'm receiving SSI, still doesn't justify that
Right.
I receive $17 a month.
Have you thought about going to the Department of Human Services or the aid office, the public aid office, and doing what Jimmy suggested?
I'm thinking about doing that
It
because,
sounds like you might have some success.
yeah, because it's like $17 a month.
Yeah, you could probably make a pretty good case for yourself as long as you had all your documentation when you went there and you were prepared to spend some time there.
Yeah, because the DHS office, let me tell you, you go in there, you take a number, you sit
Right, right.
down, and sometimes they have you waiting there for at least 30 minutes to 2 hours.
Right, you have to be ready. Yeah,
Depending on where you go.
right.
My situation with different sites, I've been to the downtown office, in and out in an instant. I've been to the one in Wilson, have to wait 3 hours.
Mm-hmm,
And I've been to the one on the south side,
mm-hmm.
same thing, 3
Right.
hours. So it all depends where you go as well, I think. And
Right.
you gotta be there early as well.
Right. So that's the other piece of advice. Get there early, get there prepared, and be prepared to spend a fair amount of time. It's great if you get to leave early, and if it's just, it might take more than one visit. So I think, these are things we've got to think about, and Tom and I will try to after the holidays, try to do a little more, we'll touch base with people and maybe do a focus group to see if we can come up with some better solutions. I'm going to need to move on to a few other things. Now, the next subject I'm going to mention is kind of personal, but I'm going to mention it anyhow. We've been getting a lot of complaints from people who cannot get catheters. And I know that's a personal experience to help manage our bowel and bladder program. But the fact of the matter is, it's really difficult if you cannot get a catheter, and that we're hearing more and more that it's getting harder to get them, and people are reusing them, and it's a very dangerous situation to do that. So what Tom and John Abate and I want to do is, if you'd be willing to speak with us privately about some of your experiences with needing to get catheters or your inability to get them, please share them with us, and you can do that privately with us. We're trying to understand if the cuts in Medicaid are severely impacting people's ability to get incontinence supplies, and we know this is a very big issue. So please contact us personally, either at the meeting here or sometime afterwards. And if there's anybody wants to make a public comment about incontinence supplies or catheters, we welcome that too before I move on to wheelchairs. Okay? And then wanted to mention a couple things about our wheelchairs is that Tom organized a meeting for several of us, John Abate and Obla and Justin and Michael Grice, to visit HFS to start talking about the problems that people are having in getting batteries replaced for their wheelchairs and getting their repairs, and also just getting chairs, and also the problems they were having with loaner chairs. So we were able to meet with the legislative staff in Chicago and in video cam with the legislative staff in Springfield. I think that they were pretty attentive. They said that they were still working on dropping the doctor's pre-authorization requirement to get our batteries replaced and to get repairs on our wheelchair. They said that those pre-authorization requirements should already be dropped. So if you are experiencing a situation where you're not getting timely repairs on your chairs and you're running into problems where they're making you get doctor pre-authorizations before you can get your batteries replaced, please see Tom or me. And we're trying to follow up and give them a list of names of people who are running into specific problems with either battery replacement, repairs, or loaners. So please do that. Anybody have any stories they want to share about that?
I just have issues with repair on my wheelchair. Aetna says that it's a specialty wheelchair for wheels, and it's just a regular wheelchair. It's something that you use to get around every day. Or you sit
Is
on
it a
the couch.
power chair?
Nope, it's just a regular Tylite chair.
It's a manual chair.
Manual chair, and they say it's a specialty. And then when you appeal, it's supposed to be 30 to 60 days to get back to you, and it's been over 120. So my option is to go to the Illinois Insurance to complain to them and write a letter, because I think timely manner means if you say 30 to 60 days, it really shouldn't take
Right.
that long to get back to you.
So are you dealing with, you said you're going through Aetna?
Well, I talked to National Seating Mobility. and
Right.
They can't do nothing unless the insurance okays it, so I
Right.
took it upon myself to appeal it. And now Aetna's coming out of Chicago, off of, you have to, it's just I'm done.
Well, we can't guarantee results, but we really try to help advocate wherever we can so people don't get caught up in this finger pointing thing where National Seating and Mobility is pointing the finger at the insurance company, and the insurance company's pointing the finger at the rehab provider, the seating and positioning people. I mean, it just goes around and around and around. So we can't guarantee total results, but we're definitely interested in hearing stories and trying to assist you in the best way we can to get your chair, as long as you make an appointment with one of us. Okay? Evelyn, too, right?
Hello, this is Evelyn, and I want to say that I am very concerned about the situation. I am 65 years old, and I have My chair, I've been having issues with my chair.
I gotta hear
So
her.
when I called the vendor to have them come out to evaluate my chair for repairs, they told me that they could no longer come to my home because of the changes in insurance or cuts.
Now,
in
who is
medi-
this, Evelyn? Who's telling you this?
My vendor. This is, I forgot the name of it.
Is it National
Not-
Seating?
No, it's not with them. No, they lied to me. That's another issue
Okay.
about, but this is, I had to move on because they told, National Seating and Mobility told me they didn't accept my insurance. So they gave me a whole list of.
Has your
vendors.
insurance, and your insurance hasn't changed?
No, it's been the same. So, going back to this vendor, and because of the changes in Medicare and cuts, they are no longer able to come to my home for evaluations or nor repairs. They could, however, I would have to pay.
Interesting.
Yes.
And these are
And the
Medicare,
options-
not Medicaid
Yes,
cuts.
Medicare, probably Medicaid, but I believe it's Medicare. And the other option is that I can take it to them, which is.
It's hard,
not-
because you gotta get a
no,
ride.
It's just not
and-
practical,
and the
no.
cart
Can you imagine
and
if my
the
chair
scooter-
is,
Right.
well, if it's not moving, how am I
Right.
gonna
You
get
can't,
there?
yeah. I mean, so that sounds like
that's
something
an
we really
issue.
gotta address, that people
then-
can't bring their chairs in to get repaired when the chair's not working.
Exactly. But but here's the thing, they're charging for an evaluation only.
Right.
It's like, I believe, $75.
Yeah.
I was quoted. Then for repairs, if they were to do repairs, let's say if I'm getting a new battery or something, or a leg rest, which is what I need, that
Right.
would be starting at $150 an
And this is
hour.
out of your pocket.
So, yeah, so.
Okay, it sounds
I'm
like
having an
something we
issue
really
with that.
gotta spend some time
So,
talking
yeah,
to you about,
definitely.
and getting an appointment with you too.
Yeah.
We've got, I think Tom wanted to make an announcement before we go on to our next speaker. I want to thank everybody for sharing your food stamp stories, your wheelchair stories, and anybody wanting to share catheter stories with Tom or me later on privately, please feel free to. And Tom, you're gonna.
Judy, I think we're
Oh, wait a
gonna
minute,
go-
we had one last comment.
I just want to say one thing on that. I have Medicaid, so I'm a little different from her. But what I did was I called the people Orbit who does the chair, and they were giving me the runarounds. So what I did was I got my health care provider on the line, and what they did was put the other person on the line, so we was all three on the phone.
Okay,
So what they were telling me was different from. they
Right,
was
right,
telling-
right.
So if you get them all together, then you will get results.
and we can't do that with everybody, but sometimes we can help facilitate that a little bit. I think you're right, Jimmy. It's just that with the power wheelchairs and the wheelchair repair, they're always pointing and blaming the other party, and we're always caught in the middle, and whatever it is, they're telling us it's the other person's fault, and it's gotten worse.
Judy, we have one more
Okay.
comment over here, and then
Okay.
I'm going to have you introduce Barbara, and we'll take care of the other business at the break, okay?
Hi.
One comment.
Hi, my name is Lindsay, and I have a rollator, and it's currently supplied by my nursing facility that I am at. And I have tried to contact Medicare in order to get my own rollator. And Medicare says that while I'm at the facility, I cannot obtain my own rollator. But the facility refuses to get me one that works for me. So I am caught between a rock and a hard place.
Right, because you need your rollator to live independently, and they're saying, we'll give you one as long as you stay in an institution, which is kind of a catch-22, and not uncommon. Are you working with any rehab providers? Are you working with Schwab or Shirley Ryan or RIC?
Not currently, no.
Yeah, that might be a way we can talk to you privately about that another time. I think we're going to have to conclude this segment. Just in summary, we've talked about food stamps and maybe trying to do a focus group on that and learning about better strategies to appeal for the reductions in food stamps. And we've talked about the need to get access to catheters when people are reusing their old ones because they can't get new ones. We've talked about doing some troubleshooting and advocacy work around getting wheelchairs repaired and trying to get out of that vicious cycle of finger pointing between the supplier, the insurance provider, and the rehab person or whoever. So again, Tom and I and our intern John Abate are here. We can't solve all problems, but we will definitely help advocate and try to do what we can to help people advocate for themselves and get solutions to the problem. And we'll share any productive strategies that anyone wants to share with us. Does anybody live with chronic pain issues?
A lot of hands.
And
A lot of hands.
are people that are living with chronic pain issues feeling like they've got their pain controlled adequately? So because of this, because of the situation where opioids are getting harder to access even when they're legitimately needed by people, some people asked us if we could have a speaker to talk to us about pain medication and ways to manage our pain that are affected given what's going on with the opioid crisis. So Tom and I reached out to our very good friend and colleague, Barbara Shaw. Barbara is a doctor, a PhD doctor, and she's also a nurse practitioner, and she's also a teacher at Rush Nursing. Yep. Nursing, and she's going to tell you the rest about her credentials because I don't have a little bio, but she's somebody who's worked very closely with Access Living and the disability community, and she's well-versed in disability culture issues, and she's going to share some of her thoughts and her experiences as a clinician on the subject of pain control for us.
Well, first of all, I want to tell you that one of the issues that's come up nationally, as you well know, is the issue of overprescription of opioids in this country, and that is true. In fact, the United States is 5% of the world's population, and we use 85% of opioid prescriptions worldwide are from the United States, okay? So this, in and of itself, opioid is not bad necessarily, but it has to be used judiciously. It has to be used for the right kind of pain at the right time and for the right amount of time. And we've seen a lot of people, unfortunately, overdosing and dying, so now there's a lot of public attention to this. Unfortunately, there are some providers who've been giving out this medication for years like it's candy and not really checking, and so the problem has grown a lot. So opioids work on a part of the brain that helps with decreasing pain sensation, okay, the sensation of pain. And the CDC right now recommends for acute problems using it for 3 days only, okay, which is not a lot. For chronic pain, they recommend no narcotics. They're recommending acetaminophen, so that's Tylenol. They're recommending Motrin. They're recommending cognitive behavioral therapy. They're recommending exercise and antidepressants because all these things have been shown to have an effect. In fact, there have been some studies showing that opioids are equivalent, or like taking Tylenol and an ibuprofen together can be as efficient or as good a way to control pain as opioids, although I don't really know about that. I think somebody living with really severe pain, huh? Yeah, no, right? Right. So like cancer pain, somebody who's been having a lot of pain may not really respond to that. And that's one of the bad things, right? There's an acknowledgement that there's a problem around the country, and now the backlash is don't give any of this stuff out, right? So certain people, like people who are living with disabilities, have legitimate needs sometimes for these kinds of medications, but they're going to be much harder to get. That isn't to say that pain can't be controlled in other ways, but it is going to be harder to get. And unfortunately, I have some, I've read something recently that also people with disabilities are very, very high consumers of opioids and narcotics, and that isn't necessarily always necessary. Sometimes it is, but not always. So there's no word on the use of like alternative treatments like acupuncture and medical marijuana, which I'm going to be discussing. But this is, I can understand how it would make people feel very anxious and afraid, because living with chronic pain is no joke. It affects your mood, it affects what you're able to do, obviously. And so it is something we need to take really seriously. So I wanted to give you some information about what we mean by pain, okay? Pain, obviously, is a very subjective thing. I could get, hit on the head by a brick, and I may say, oh, that doesn't hurt. Somebody else might get hit on the head by a brick and be in the most pain they've ever had in their lives, right? So the hard problem is that we can't easily, anything that, that's why we ask people, what is your pain on a scale of 0 to 10, which is kind of goofy, but it's to get a sense of really how bad the pain is. But it's your feeling about the pain that counts, right? We don't have a way to measure it very well. We do know that certain conditions are going to make you feel a lot more pain, other conditions not so much. So that's the thing. But when you go in to see a healthcare provider, the thing that's in the person's head, and this is important for you to know, is they're trying to evaluate what kind of pain this is in the first place. So there's a really fancy word, called nociceptive pain. And that's a kind of pain that happens in response to an injury to some tissue. And tissue includes skin, bones, and everything in between. So it's due to an accident, an injury of some sort. That's nociceptive pain. Then there's something called neuropathic pain. And that has to do with sensory problems, numbness, hypersensitivity, hyperreactivity, tingling or paresthesias. And some examples of that, as you well know, are related to spinal cord injury, diabetic foot pain, phantom limb pain, and stroke pain. Okay, so we've got neuropathic pain and nociceptive pain. And there's another kind of pain which is inflammatory. And it's I'm not going to get into the physiology of it, but examples of that are rheumatoid arthritis, irritable bowel disease, things that have to do with inflammation in some tissue or organ of the body. So when you're going in to see somebody, they're trying to figure out, these don't happen alone necessarily. You can have two types of pain. But they're trying to map out where this pain is coming from. That's the thought. Not only that, we're trying to figure out the intensity, So often I'll say, like, the most pain you've ever had, like awful, awful, awful pain. And people are so worried about this that they'll often say 10, when they're sitting there texting on their phone or something. It's obviously not, stopping them from doing things, but people get very anxious about this and they want help, so they'll say it's like the worst possible pain. So we try to find out what kind of pain it is, the amount of pain it is. How long, is it something that's just happened, right? Is it something that's been happening on and off? Is it something that's happening every day? And under what circumstances, right? Like, is it when you get up to walk? Is it when you bend over? Is it in a certain, if you have diabetic foot pain, is it in a certain foot and hurts more when you walk, for instance? Or when you're just trying to take a bath or anything that involves movement. So the other thing we look at is the kind of tissue, like where is it happening? Skin, muscle, tendons, bones, joints. So that's the other thing we're looking at. And then we're looking for syndromes, okay? If you've had a syndrome in the past, cancer falls under that. There are people who have post-cancer pain. Fibromyalgia, that's a big one that's that's been, poo-pooed for a long time, and now it's been shown to be a real problem. Migraine headaches, somebody here said something about migraines, that as well. And cerebral palsy, for instance, okay? So those are syndromes, meaning lots of different body parts affected that are related to that one medical problem. And then there's special considerations, and this is a good one. This has to do with psychological state, how you're feeling. Are you depressed? Are you angry? Are you anxious? Are you feeling hopeless? Like, all that kind of stuff. The age, gender, your cultural background, and obviously for everybody here, we know also people being smart about disability care and recognizing it and asking about it and having you be a partner in that is really important. So, to summarize, we want to know where the pain's starting, what kind of pain it is, nerve pain, pain due to inflammation, or pain because of an injury of some sort. We want to know how bad it is, if it's acute, if it's chronic, and kind of how that happens. We want to know where it's happening in your body, more or less. We want to know if you have underlying health problems that would lead you to have maybe more problems with pain. And we want to know how you're feeling in general, right? We want to know kind of how you're doing. I don't know if anybody's seen the Cymbalta commercial with the dog that looks really sad because the dog mommy is depressed, and it's kind of like, so, and it says depression hurts, and it is true. There's a lot we really honestly don't understand about pain, and that's one of the frustrating things. We know some parts, but we don't really understand, for instance, the effect of depression, why depression seems to make pain worse. So there's the opioids, which, as I said, can be useful, but are going to be very tightly monitored now. So people are more reluctant to give the medications because there is actually even a possibility of being censured or having your license revoked or suspended for a while. What are the alternatives? Does anybody want to name for me like an alternative to narcotics that you could, yeah?
Going to a pain clinic and possibly getting injections.
Injections can be helpful, but injections are usually limited to 3 in a year. So for a lot of people, it may help a little bit, but not for a long time. And the problem is they often have prednisone in them, and that can affect the bones, actually. It kind of eats away at them. But that's, yes, absolutely, that's one possibility.
But it also, as in my case, can help understand what's underlying.
Wait, I didn't hear you.
What is causing the underlying pain?
Right, right.
I'm 48 years of age. I'm going to explain what I know pain to be. I have multiple of migraine headaches every day, every day, all of my life. My threshold for pain is so high. For example, when I recently went in for rotator cuff surgery on my shoulder, I asked the surgeon, do they really need to use painkillers and or general anesthesia? Because really, I don't think it's really going to hurt me, knowing my threshold for pain. Never in my lifetime, still to this day, at 48 years of age, never in my lifetime have I taken but 3 actual pills in 48 years of opiate for really good reason. For me, opiates are probably the worst thing that I could ever put in my body. Number 2, those who are addicted to opiates and now don't have access to painkillers, I'm really concerned about, yes, what you have brought up, doctor, the psychological ramifications of that. Because that is one of the most
Yeah.
difficult things to deal with.
Yeah, Bob, can you turn it into a question if possible?
That's the question that I have, is how does somebody wrap their mind around not being able to get the opiates, not being able to manage their pain, and psychologically, what does one do?
Okay, well, that's a great question, and I'm going to discuss that a little bit later, but I just want to see if there's any other alternative pain control or pain management modalities that anybody here believes is helpful.
Hi, my name's Angel. I deal with a lot of chronic pain. In 2014, I had a spinal fusion at Johns Hopkins University. It's like one of the best hospitals in the country. It was a 16 and a half hour surgery. They like cut me in half for 8.5 hours and then sew me back together. Then the next day, open me up again, right? And then I was in rehab for like a month. And so then after this or whatever, like I was getting pain medicine and I was observed, but no one told me that like I was gonna have to have a pain specialist when I got out. So when I went to go ask my doctor, like the same doctor I've been getting it from, if I could get pain medicine, he refused. He said I couldn't get it from him. I need to find a pain specialist. Well, I was like, what is that? So I just had to suffer because I had a hard time finding a pain specialist. Then you have like a long wait for pain specialists. So part of it is like education. Like you need to educate people about what their options are.
And that's why I have the paper that I made for you guys, so you can see what different options
But
you
also like educate
have.
people about what the symptoms are of addiction, like what they should watch for. Educate your family about what they should watch for, and stop like painting all of us as like drug addicts. And I don't even trust this great concern for opiate addicts because there's not a lot of concern about any other type of addicts in the country. So I don't really see why there's this big split between the two. But my frustration is that I've been documented like to have significant disabilities, and even when I've done everything I'm supposed to do, like it's all these barriers to get your medication. And now I have a prescription, but like then you got to go from pharmacy to pharmacy because they don't want to fill it, or
Right.
it'll take like 2 weeks to fill it. And if you have a disability, like how are you
Well,
supposed to do that?
I mean, that's a
So-
sad statement about the reality of people with disabilities being generally not evaluated and treated properly, right? And for the disabilities to sometimes be in the background, people not talk to the person with the disability and really get their perspective on what's happening. So I think it's a really sad statement, right?
So are there any changes that are being made in the structure in terms of what the medical profession is supposed to do to observe their patients better, to assess what their needs are, to believe them when they say they're in pain? Because I got a PhD, so I was taking opioids, but I wasn't an addict. I mean, not that you couldn't be an addict, I guess you could. But like I was very observant of myself. So like they need to observe the system and figure out, you know, how they can better treat people with different needs, instead of like, you know, it needs to be a more holistic perspective, I guess is what I'm saying, because my experience is that the doctors, they're just worried about not getting a lawsuit, and they try to they don't want to write those prescriptions
Right.
anymore. And then that means that we just have to suffer. And there's also a racial and class element because people of color are not believed to be in
Right.
as much pain as you have sickle cell anemia or something like that. Like we're just assumed that we're drug addicts. So I just wanted to ask about like the structural issues, not just what we are supposed to do, but what are the people who get paid to serve us? What are they supposed to be doing, and how can we advocate for ourselves to ensure that they're doing what they're supposed to be doing for us?
Okay, great.
Hello, my name is Curtis Harris. I'm an advocate here, and what I would like to have say is that pain is real. Is that many of us have gone through pain so many years. It's something that has to do with opiate addiction, which I don't have, but I do have osteoarthritis in my right knee, and that I have been taking all kinds of painkillers. And I'm still taking that, And I don't know if any of you have gotten physical therapy for your knees, legs, and right, and due to the mental issues problems, I also don't even worry about physical rehab of my knees and legs and focus on mental health first, which is true because you got to have both.
I just wanted to share a small alternative to medicine. Is I have a lot of inflammation pain from rheumatoid arthritis, and my nurse told me many years ago, if you could do any kind of exercise, don't worry about how rigorous it is. So I have this exercycle. It's really a lot of work for me to sit on the bike and keep my balance on it. But she told me even if I didn't put it at the highest speed, even if I had it on the lowest speed, and I could do it regularly every week, it would help reduce my inflammation, which would help reduce my pain. And what I've done is I've kept it, like, say there's a speed of 1 to 10. I've kept it on the speed of 2. I've been doing 15 minutes per day, 4 days a week. And what she told me is if I did exercise like 2 times for 15 minutes a day, it was the same benefit as if I did exercise for 30 minutes at one time. In other words, you can do small amounts of exercise, even if it's not the highest power, and you can still get benefits to bring the pain associated with inflammation down. So that was one experience I've had of controlling pain that wasn't involving medicine that actually has been working for me.
That's great. That's
So
great.
I don't know if other people have things that have worked for them that are not medical.
Okay, we're going to have about 2 more comments. I know Barbara has more to add from her prepared statement. Maybe 3. I see 3 hands. Let's go through, keep it to a question or a short story if you can. Go ahead.
I have chronic pain. It's a 24-hour, 375 days out of the year. And I go to the doctor, and the first thing they give me is some generic Tylenols and stuff. All this generic stuff doesn't work for me. It doesn't, I don't even take it because it got too many side effects, liver, pancreas, heart slow down at nighttime and all that kind of stuff. I deal with my pain on my own because I'd rather not take a lot of stuff that's going to really damage me, like the Tylenols, the ibuprofen, and all that kind of stuff. Because when you're a certain age, I'm 72 years old, and you get a certain age, those things go against you. And I don't. I'm trying to make 100.
Whoa.
You know, so pain.
Yeah, what do you use? The question was, what do you use then?
Nothing, I just bury it, because if I stop having pain, I think I'm dead.
I'm sorry.
So, I live in pain. I'm in pain now.
That's
I had
funny.
my tailbone cracked. I fell in my bathroom and hit my head. The doctors wanted to know how come I wasn't dead. I told them there's a God.
Keep the mic close, please.
He was in the bathroom with me that morning, and they was telling me I should have been unconscious. I should have probably wouldn't have woke up, but I did. And I still have pain. You know, it's a chronic pain. My back, my spine is crooked. I got the spinalosis. They want to do back surgery. I refuse because kind of my age. And like I said, I don't take the medicine because there's too many dialysis clinics. People are taking this medicine. We got more dialysis clinics than we have hospitals now. You know, so we have to be careful of what we're putting in our mouths. And like he tell, taking it till it stops. What am I take the pill for? If I take it a week and I'm still in pain, I don't need to take it no more.
Okay, let's hear from Chewy.
You know, doctors are good for making money. Let me start by saying that. You know, when you go to the emergency room, the first thing they want to do is give you pills after pills after pills. Then you get out of the hospital. They prescribe you pills and pills and pills. So the last time I went to the hospital, I had a strong fever. I was dehydrated, not drinking enough water. That's another story. But what was curious enough is that I was having these migraine headaches, on and off headaches. throughout the day. And I told the doctor about that, and the first thing they came out of their mouth is, well, why don't we give you ibuprofen and 600 milligrams? I'm like, whoa. So I told the doctor, is there something easier than that? Because I don't want to depend on medication. He's like, well, you could do exercise, you know. I'm like, well, I've heard that here and there, yeah. I know I'm doing that as it is, but is there anything else than just exercise?
Okay, let's let Susan have her statement, and then I think we'll hear some more options or things that are available, possibly. Susan's in the blue, right over here. No, up here. Raise your hands. There.
I found that exercise helps me too, but I've had the reverse. Like if I go in with head pain, they immediately want to give me morphine. Hydrocephalus. It's
Yeah.
pretty common.
Okay, thank you.
Okay. Thank you so much for sharing that. I want to hit all these points. I just want to say first that it is kind of true that this country is pill happy. Right? I mean, that's like the first thing people will go to. And I think, and it's really unfortunate, Chewy, that you had this experience, but it is true that healthcare providers are often under such pressure to produce, revenue, that the things that we really need to talk about, which is to really sit with somebody and listen and find out what different kinds of alternatives might be valuable to you. People, I think, often feel like there's just no time. So it's just easier to write a prescription for a pill. And that's sometimes the worst thing that you can do, is to just take pills and pills and pills. Because lots of things like ibuprofen can have a really terrible effect on your kidneys, for instance. Okay? So, right. So what I wanted to just turn the discussion to is some other alternatives to think about. The unfortunate thing is many of these things are not covered by insurance, right? And that's a way bigger issue because that's a systemic problem in this country that we don't, things are run, healthcare is run as a business, it's run on a profit model, and there isn't a lot of interest in doing what really needs to be done to take care of people, in my humble opinion.
That's right.
So, medical marijuana, let's start with the fun one. Okay. It is coming here. Marijuana functions on something called the endocannabinoid system in the brain, and that's a lot of long words, but basically what it is a dimming switch for pain. It can be useful in many kinds of pain, not all. So that's another thing to remember, not everything is going to fix the pain, but it can be really helpful in spinal cord injury, okay, muscular dystrophy, multiple sclerosis, seizures, Parkinson's, nerve pain like I talked about, the neuropathic pain, spasticity, okay, Crohn's disease, glaucoma, it's routinely, people will use it for glaucoma, fibromyalgia, and of course cancer. The problem again is getting it. Now, there are some providers who probably will never write for this stuff because they just don't believe in it, right? But there are places now where there are providers associated with some of these medical marijuana centers that are way more open to the possibility. And what I've read about this in general is it's like one, and I'm not saying you should run out and get marijuana, but okay, like one puff 3 times a day can really help with a lot of these issues. It's not like you have to be smoking all the time, because the other thing is, what if you have chronic obstructive pulmonary disease, right? Well, then you might need edible marijuana. You wouldn't want to be smoking it. So you have to think about all those things. Okay.
Patches?
So acupuncture, what'd you say? Brownies, yum. Okay. Acupuncture is another proven way to decrease pain. It has, over at Rush, we have somebody in the cancer center who actually does acupuncture for people. Yeah, but it's not very common. And some of the practices that have it are those really high-end, like concierge doctors who, like, you know, they'll have all this fancy other stuff in the office. But acupuncture for real can, it stimulates the nerve pathways, and it can change the way pain is perceived. And so it kind of gives a message to your brain saying, oh, that isn't so painful, right? Can it work for everything? No. Just like allopathic or Western medicine can't work for everything. It can be useful for my migraine people here, for migraine headaches, arthritis, allergies, asthma, sinus problems, headaches, back pain, sciatica, anxiety and dizziness, high blood pressure, chronic fatigue, post-operative recovery. So there's a wide range of use for it, but the problem is accessing it at a price point that you can afford, really. Another possibility is chiropractic. We all know what that is. It's not going to be okay for everybody, but it might help some people, particularly with back pain and with sciatic pain, the pain in that big sciatic nerve. Another kind of medication is, in addition to injections, are pain patches. Now, some of these are actually narcotics, but sometimes they just really have to be used if you have intractable pain that just does not go away, right? So one of them is called fentanyl, and I don't know if you've heard anything. Has anybody ever had a fentanyl patch who has chronic pain? Yeah? Does it help you? Mm-hmm. Yeah. So it can be very successful, but it does have serious interactions with other medications. But sometimes it's really the only thing that works. So it's, I would never say don't use it, but it unfortunately has the bad rap of being used along with heroin to potentiate or make a high, well, like really like intense, and it leads to death. So when it's used correctly for somebody with really bad pain that kind of, it just does not go away, it can be useful. It can also cause, any of these patches can cause skin problems as well, so that's another issue. Okay, buprenorphine. That also has addictive potential, but it's used for people often who are addicted to heroin because it works just a little bit differently, but it works on those same pathways. And it's legal to use. You know, you can't like prescribe heroin generally. So it's just another patch that can help with pain, but it's related to addiction. Lidocaine, I'm sure people have had to have lidocaine patches maybe. Anybody? Lidocaine, yeah. Lidocaine is just something they use to, you know, like if you go to the dentist and to dull the pain. But it's a patch, and you put it on the area that's affected. So other things could work, like the fentanyl and buprenorphine will work on your brain transmissions, whereas lidocaine is more like you put it on the part that hurts, and it's an anesthetic. It'll stop the pain, but not at a very deep level. And another thing is that a lot of people use is capsaicin. Anybody knows? It's really hot pepper is what it is. And you find them in like those back patches that you have, and it can be quite useful, but not so much for chronic pain.
Yeah.
Nerve stimulation. Has anybody heard of this?
Yeah.
Like the TENS unit, the transcutaneous. This is a big long word. I'll say TENS. Basically, they're electrodes that you put on the part of your body that hurt, and then you get a very small amount of electricity, and that starts to affect your neural pathways and the perception of pain. And then there's another kind that's being used more now, especially in people with spinal cord injury, cranial therapy, electrical therapy, where these electrodes are clipped to your ears. And the idea is that the pain works, it works on your brain itself again. So that's different than the kind that is just put on the area that's in pain. Another thing that's new, and I didn't put this down here, is magnet treatment. This is something that's relatively new, really generally is not covered, unfortunately. Physical therapy, as some people said, can be really good. Exercise can be very, very helpful because it increases your body's happy chemicals. So you literally feel better because you have more of those chemicals floating throughout your body. And it doesn't have to be, as Judy said, a lot, but just kind of getting moving can be really helpful. Massage, who doesn't want that, right? That's lovely. And now to your question about how people with addictions are dealing with this, I've seen a lot of people who are super anxious about it, and frankly, they go out in the street and get it. And that'll still be the case. They'll get that. But what I've been doing with patients is to work with cognitive behavioral therapy. Does anybody know what that is? Anybody? Nope. Okay. Well, it's this newer kind of therapy. It's not the Freud kind where you sit on a couch for 20 years. It's where you take a specific problem and you frame the problem in a different way. And framing the problem in a different way has actually shown to make changes in cells even at the genetic level. So it's not to be, it is something to be taken seriously, but I think in somebody who's in serious chronic pain, to say frame your pain in a different way at first may not be the best thing, right? You want relief. You want quicker relief. Mindfulness, that's a big buzzword these days, okay? That's another thing. That's just allowing yourself to kind of observe the pain. I guess that's a way to say it. Like you observe it and put a distance between yourself and the pain. And the idea is that it becomes less painful because you're less focused on it. Self-hypnosis, weight loss, that's a biggie. Because if you think of your body like a hanger, a wire hanger, and if you put a big fur coat on a wire hanger, what happens to it? It falls down, right? Well, that's what your skeleton is basically, right? Your skeleton holds up everything and gives a place for your organs to stay. So if you're seriously overweight, and I know this is not an easy topic, but that will put more pressure on everything. So that's another thing to just consider. And then the other thing is Ayurveda, which is a new agey, but not really because it comes from India from thousands of years ago. But there are some things like turmeric that you can get now that actually can decrease inflammation. So those are just some ideas of things that you can use or try in combination, understanding what your kind of pain might be, and to advocate for yourselves, because that's the only way this is going to get changed, really.
Okay. Let's give Barbara a hand. And I think we do have one question here from Christy. We'll try to get that one question in.
I have a comment, actually. I've had a stroke back in 2010, and I take 19 pills a day. I went from taking no pills to taking 19 pills a day for various things, and I'm at the age where women start going through physical changes, female-wise, and my gynecologist that I'm going to now is tried to talk me into taking hormone replacement drugs. I said, no, I am not taking hormone replacement drugs. And she asked me why, and I said, because I don't want to be at risk of having another stroke because I was on birth control pills. That's what caused me to have the stroke.
Okay, thank you, Christy. Let's give Barbara another hand.
Well, thank you, and be well. And remember, in a medical encounter, you're in charge. You're in charge, even if it may not feel like it. You're the boss.
That's a great lesson. You're in charge. We like that. Okay, thank you. Thank you again.
Yeah.
Okay, we're going to kind of skip the break here. We're behind schedule. If you need to step out, that's fine. The class, well, how to introduce this? That'll be the question. Access Living, and particularly the group Independent Voices, has collaborated with Joy Hamill's OT class on multiple occasions, and every time it's been a very productive collaboration. And we're very happy to have mainly the students, but there's some of the people who were the mentors are here as well. And I'm going to turn it over to Joy to introduce the topic even more.
Hello, everyone. So you've seen us here before. We've been with you for about 20 years, working with Access Living, and Tom and Mary and many of the folks in the audience here. How many of you heard of the Stepping Stones program, or you've been a part of it, right? That's what we did a long, long time ago, 20 years. We got a grant together to develop that, and you've now taken it, and we know that over 500 people have been through it. So good for you. You're the only program in the country that has a disability-led community living, getting out of the nursing home to the community program. The only program in the country with it that's funded, right? So we need to fight to keep it going, right? Yes? And part of the fight means we need to keep getting the next generation involved. And so what we're doing with Tom this semester is we've had a class called Action Research over at the University of Illinois at Chicago. It's all about learning about social justice, and it's all about hearing the voice of you and trying to document it for you so that you can use it for actions, for systems change, for these kinds of things. And so what we did in the class is we paired our students with a bunch of mentors that they're going to introduce to you. Some of them are here from Access Living, and we also have a young group from Urban Autism of some young gentlemen who are joining us for the first time ever here at Access Living. New to the disability rights community, so I want to make sure that you get them going on disability rights. So they're going to just present very quickly to you what they did during the class and what they learned about people getting out of nursing homes and into the community for this first group, and what were the major things that they saw as barriers and supports to that we can work on as a group. Okay, so I'm going to give the mic over to them and give them a big round for presenting.
Woo! Hey, everybody. So make sure you stick around because we're going to have catering from Soul Taco. So don't leave. Hi, we're grad students from the UIC PAR class, Dr. Hamill's class. We've had so much fun. And we'd like to thank our peer mentors. Bob unfortunately stepped out for a drink, not an alcoholic drink, but a drink. Maybe he did, I don't know. But Jasmine, we'd like to thank you profusely for being our peer mentor for PAR. Thank you. And Shelly, of course, thank you so much for being our peer mentor. And we've had a satellite peer mentor is Jimmy, so he's doing his duties right now. So we are Andrea, Carol, Gabriella, Glenna, and Lori. And for this project, students and community members partnered in Participatory Action Research, or PAR, to identify supports and barriers to transitioning out of nursing homes into the community, and supports and barriers to independent living in the community. And in this class, we had so much fun. We were researchers, and we worked with the community members and peer mentors to come together to work on important issues that members experience. So we collected information using the focus group, photo voice, and social action, which is, you see the different rounder signs. We did a protest with ADAPT and SEIU. And Tom will talk about future actions with that, which is PA cuts and overtime policy for PAs for persons with disabilities. So we analyzed the results to design action plans and influence policy change. And one of the methods you see here on this this PowerPoint right here is we had a photo voice. We also had the focus group, which is the barriers and supports that you voted on. And what you see here is we spent a day in the community with our peer mentors. There's Evelyn. And we worked on seeing through the eyes of our peer mentors. So we came back together and discussed all the salient points, and we were able to see through the eyes of our peer mentors to see what they're experiencing in their communities. Also, a unique part of PAR is the social action component. So we partnered with our peer mentors to protest Rauner's recent cuts to PA, raises, and overtime, which directly fuels the barriers of the lack of finances and social supports necessary to community living. Here's Jimmy. He's another peer mentor of ours. Thank you, Jimmy. Yeah. So we just want to say the experience of working with peer mentors about barriers and supports to transition living out of nursing homes into the community was invaluable. So now we're going to have Glenna and Gabriella talk about these barriers and supports that you guys actually just voted on right now.
Hello, everyone. Thank you so much for having us. I'm going to let Gabby start.
Hi, so I'm Gabby, and this is Glenna. And basically what happened was we held a focus group. And from there, we were able to identify 4 major themes, being supports and barriers when transitioning from a nursing home to the community. So when people were coming in today, we had everybody vote. And we gave people stickers, and we had you guys vote on what you identified was one of the major either barriers or supports during that transition. And so Glenna will speak on the barriers.
Oh, thank you, Jasmine. Thank you. Okay, so the 4 major barriers that came out of the focus group were a lack of accessible and affordable transportation and housing that would make it difficult to move from a nursing home into the community, and then stay in the community once transitioned there. Also, a lack of finances before leaving and after transitioning out of a nursing home. Also, a lack of social supports and social stigma, being either having come from a nursing home or having a disability. So those were the 4 major barriers identified from the focus group. And today from the voting, many of you who came in, we really appreciated your input and also some additional barriers that you shared with us. And the top barrier from today's voting participation was a lack of finances in and out of nursing homes. And with that, I'd also like to give Shelley an opportunity to share one quote that came out of our focus group about barriers.
Okay, excuse me. Can you guys, would you hold the microphone? Yes. Microphone, but one of the important quotes that we were talking about, that we talk about accessibility. Anybody that knows me, okay, Troy, thank you. We're not asking about for something special. We're just asking for a human right. It's important that the people in disability community and outside know that we can bond together, because there's a lack of funding and lack of everything. People are constantly, especially in nursing home, are pushed aside. So let me read this one to you. So we're not asking for something special. As you know, we are a person, people with need in a wheelchair. If you guys look around, there's one picture in particular where you see myself and the doctor and the ambulance. They're sitting right behind us, and accessibility is important. They think that people in nursing homes or people in wheelchairs don't have to go to the hospital, and we're left there. So I'm back and forth to the hospital so much, and then it was ironic that myself and the doctor found this one picture and had to make a quote out of it, because they just wanted me to leave my chair and just ride along. So I just want to thank all of these organizations for everything. Big plus to my students, for all of you. And I'd rather go to jail than to what? Who knows else? All right, I'd rather go to jail than die in a nursing home. Okay, that's right. Thank you guys.
Thank you so much for your input, Shelley. And Shelley's already spoken on some of the major supports that were identified from the focus group, being that of Access Living. Also, some participants today of our voting activity also spoke on ADAPT and Chicago Hearing Society. Community networks and supports that can support while transitioning. Also, other identified supports were involvement in disability rights advocacy, opportunities to get involved as activists, Also, community engagement, especially affordable and accessible engagement opportunities, and also the peer mentoring program. So today from the voting, it looks like involvement in disability rights advocacy is the most important support for transitioning from nursing home to the community.
So now what we'll do is we're going to have some peer mentors from the focus group actually speak on their experience as being a peer mentor and working with us students.
The first question that we want to ask, I know Jimmy wanted to speak on this, was what was one takeaway from your experience acting as a peer mentor for students at UIC?
Hello, everybody. It's Jimmy. I got a lot out of the class. I think they was looking to get things out of us, but I actually got some things out of them as well. The support that these young people are putting forward is very important. It's the same support that we got when we come here and got involved in the Stepping Stones program. For one, it taught me to be prepared, and something that I never did before I got involved with this class. Mary can contest to it. Is I make copies of everything. If you give me a piece of paper, I want a copy of it. If you keep your stuff in line, it would help you out immensely. Never know when you might need that stuff. So let me see your board again. That one she's got. Yeah. No, this one here. The peer mentoring program. Again, once we graduated the class, we were able to get involved in being peer mentors. Once you learn something, you really should be thinking about giving back. So what Mary did, it was, I don't know if it was her idea or not, I'm quite sure it was have us mentoring people that were coming to the class. So if they are still in the nursing homes, we get a chance to either go to them or have them come to us and just listen to their problems they're having, which is some of the same problems that we had when we were in nursing homes, like finding out the financial ins and outs. I didn't know anything about that. I heard it from word of mouth about Access Living. And the one thing that happened for me that was, to this day, is one of the best things that ever happened to me, was getting Mary Delgado's telephone number. I got her number, and I was told in the nursing home that I had to get in line. So I called Mary back and told them that they told me I had to get in line. She said, no. Can you get down here Tuesday? I said, you bet your, I can't. So I went back to the person at the nursing home and said, well, she told me she can help me, just get down there. They said, well, no, you can't go. I said, well, what do you mean I can't go? I'm a grown man, you know. They said, well, we can't be responsible for you. I said, I don't need you to be responsible for me. You know, this woman is willing to help me. I didn't say it like this, but this is what I was thinking, to get out of this hellhole. And I'm going to see what she's talking about. And that's what got me here today. And now we, that graduated her class, are giving back by being peer mentors to people and letting them know that you don't have to be here. If you put a foot forward, there's people out here like us that will help you. So I think I said enough. Thank you very much, and everybody have a happy holiday.
Okay. Can everybody hear me? Okay. This peer mentor thing has been my very first peer mentor program. I really enjoyed it. One of the things that I enjoyed was meeting the UIC students, and I've got to basically make friends, and we got to go out into the community. One of the things that it's taught me was how to interact with people and how to actually solve problems that are going on in the community. We've taken pictures, we've been able to go out places, and it's been a really good experience for me. I can't say anything bad about the program. And I think I've had a lot of UIC students. Help me out. And I just want to say to the UIC students, thank you.
Thank you. Got it, yeah. To sum up, we learned so much from our peer mentors. They taught us about empowerment, about advocacy, and their stories are now informing social change, advocating for policy change, which we'll hear more from Joy and Robin. We're hoping that this partnership will continue to support these changes we're looking to make.
So finally, in conclusion, it looked like the voting we also try to come up with action plans, and it looks like Know Your Rights. Classes or groups was suggested as a possible action. Information distribution while you are living in a nursing home. So the action plan that was voted on today, we actually would like to analyze on how information on civil rights is being provided in nursing homes and support knowledge sharing to support community living. But when we're at the break and having food, if you could please talk to us about what future actions we can help you with in the future. Thank you very much for letting us talk today.
And we have one more community that we wanted to bring up here. We have a couple new folks who are joining us from it's an organization called Urban Autism Solutions.
What we did was very similar to what the Access Living Group did. So we talked about barriers and solutions to independent community living, as Joy just said. So you'll notice a lot of similar things, but a very unique take. Partially because both of our guys are in their 20s and have different experiences when you're first living on your own. So I'm going to pass this to Jen.
So first we're going to start with some of the barriers to being in your 20s and living with autism. One of our gentlemen said, "I have no guts to ask girls out." So just seeing that struggling with initiating social interactions and talking with other people in the community can sometimes be a struggle. Also, another one of the barriers was financial insecurities. So here we have Ryan at a lottery machine, and he says this is his new future because this is Chance. He's not able to get employment, or it's hard to keep employment. So this is what he does sometimes. Here he took a picture of a police car, And he says they stop me for no reason and ask if I'm smoking pot. They harass me. And we took this as like having a disability that's invisible is also a challenge and often goes unnoticed by police officers or people who feel that they're in power. And he says that they don't know I had a disability. They don't know how to approach you without having you freak out. They just don't care. So, yeah.
Well, about leisure activities, here, Mike is with us, and he says that, he likes to hang out with friends, and that's what gives him happiness. He also mentioned that he wants to be in a new relationship and have a family. And, he definitely says that, his experiences are really valuable to him now. He wants to find opportunities to do what he wants and live independently. Well, again, these are the pictures of him with us and his friend, Bob. He says, Slim, Mike, and B-Dog, we have been through it all in the past now. We'll make it all right. Follow me, and I'll show you what light means. Mike wants to be a musician. He's a good rapper. So, this is all in rap. He wants to be a musician. He wants to enjoy life. He wants to hang out with friends. And social participation is a very important part of his life. Though he did mention about the obstacles like transportation issues and not having enough money to commute. These are some of the issues that he mentioned that prevent him from having these leisure activities.
So now we're going to kind of talk about the supports that they feel that they have. So Ryan here says, ain't no mountain high enough. So kind of focusing on like his inner drive and willingness to keep pushing forward even if there are some challenges in the road.
This picture is very interesting. Mike is looking at the OT building in UIC, and he says, my life was a mess, but now I'm on my road to success. Well, he wants to be a musician, and he wants to study music, and he understands that being educated will help him towards his goal to, to being a musician. And that picture shows that he dreams to go to college.
And this is a picture of Ryan communicating with UIC students in his neighborhood that live close to their home.
And here Mike again raps, says, walking through my hometown, Chicago, that is what I grew up, now I'm the role model. Well, Mike values freedom and choice, and his biggest dream is to be a musician, as he has said. He says that though he made mistakes earlier in his life, he wants to be a role model for other people now by correcting his mistakes. And he says that he likes routine. He likes to, make music, go out with his friends, and then walk on Chicago streets. So, this is what he likes.
So these are some of the implication and action that we think should be taken. So we think like employment trainings for the financial insecurities and being able to access a job and job coaches, as well as like helping with interview skills and independent living as well. And now we want to ask Mike to just talk about his experience.
So with working with the students, I have a big honor because I always wanted to go to college and I never did. Short story, I dropped out of middle school, high school, and I was supposed to go to college, but I got accepted, then I dropped out too because I didn't think I was going to make it and stuff, because I was like getting too many fights in high school, middle school, cussing out the teachers, but they deserved it, not me. So that's what you get for making fun of a guy who's crippled and disability. I'm like, I might be crippled, but I'm a good-looking crippled guy. So I'm like, don't judge me. Right? If you can, like I say, people like don't judge me. Like I'm trying to think. Like I wrote a song called like, I'm not impressed with fake people. They think they can be real rappers like me. Okay, I'm rapping now. Like they think they can be real rappers like me. They don't know the life I've been through, so don't follow me. That's what I wrote once, and like that. And like working with these students, they're awesome because a lot of them girls and stuff. That's better because I get along with guys, but girls are pretty cool. I don't know what I'm saying, but yeah, working with students is cool because they don't know that much about me, but they get to know about me. I get to know about them. I ask them like, what's it like being in college? They ask me what's it like being in a group, not group home, I mean disability home, or whatever. And I'm like, we get to know each other and stuff, and it's cool having lunch with Mariana. I don't want to be the other women's names, but they're really nice. I'm not good at names, but yeah. And yeah, coming in front of all you guys and women, I'm honored to help you guys out and learn all your stories and stuff, and that's awesome. Knowing a person like me, you probably don't know, but I was born with prosthetic legs ever since I was 4 years old, so I'm like, people give me crap all the time, but I'm like, hey, don't be a hater, just be appreciated, like my friend Ryan says. But yeah, I don't want people give me crap anyways, but yeah, rock on. I'll be here all week.
All right, thank you guys. And what do you guys think? Do you think they could join Access Living Community and you guys could teach them some disability rights? All right, so that's the personal story. Next, I want to hand it off to Barry Taylor from Equip for Equality, who's going to give you the legal update on Olmsted and what's going on in the state of Illinois.
Thanks very much for having me. I know you've had a long session today, so I'll try to be brief, but I do want to make sure everybody knows what's the latest on the community integration Olmsted lawsuits that impact folks with disabilities, and particularly the two we're going to focus on today are Williams and Colbert, and I'll tell you what those are. So I know we have some new people to the disability rights movement that were going to be here today, so I'm going to give some quick background information just so we're all on the same page, and then I'll give you the updates. So that would be, can you do the next slide, Joy? Or great. So the good news is when Congress passed the ADA, they included the fact that people with disabilities being in institutions is in fact discrimination, and they gave a lot of examples as to why being in nursing homes and other institutions is in and of itself bad. No matter how clean or nice a nursing home can be, it's still discrimination, it's still segregating people away from the rest of the world, and that's not something that should be tolerated. And they also said that the Department of Justice is in charge of, you can keep going, is in charge of overseeing this. And so the Department of Justice said, we're going to put together a regulation called the Integration Mandate, which says that people with disabilities should be as included as much as possible with non-disabled people in our society. And that when we're talking about, and they explain what that is. And then they went on, fortunately, a couple of very courageous women went on to sue under the ADA when they weren't able to live in the community. And you probably heard of this, next slide, the Olmsted case. And this was not a class action. These were two women in Georgia who had developmental and mental illness, and they wanted to live in the community. And Georgia said, you know what, we think you're appropriate for the community. We just don't have the money to put you in there right now. You're going to have to wait. And they said, I don't want to wait. And so they sued, and their case went all the way to the Supreme Court. And the Supreme Court said, in some people's mind, sort of the same sort of importance as Brown versus Board of Education, that separate should never be equal, and that unjustified institutionalization is in and of itself discrimination under the ADA. And what was exciting about this case, next slide, was just, you know, they gave us a roadmap on how people with disabilities can get out of institutions. First, they said that treatment officials had to find the person in the community as appropriate, and if the nursing home says no, that doesn't mean that's the end. Other folks who are expert on these issues can come in and give their thoughts about it. Also, people can move as long as they don't oppose moving in the community. So if somebody wants to stay in an institution, that's different, but most people want to get out, and that's an important factor to make sure we have. We usually don't have any problem with that factor. And then the third one is that people with disabilities who are in institutions can be reasonably accommodated looking at all the other resources that are available. So what the Supreme Court didn't want people to do is jump in front of other people who had been waiting for services already. And so it's a little bit of a tricky dance because you have to figure out what the resources are and how people can move in the community. And the state can meet its obligation under the ADA and Olmsted if it has what's called a comprehensive, effectively working plan, meaning something that really looks about how people with disabilities can really move in the community. And after the Olmsted decision, you can go to the next slide, the court, a lot of states started to try to put together these plans. And I don't know there are a lot of familiar faces in this room who've been around a while. And back in 1999 and 2000 and 2001, a number of us were on committees to try to get the state to put together one of these plans. And unfortunately, Illinois was unable to do so. They put together a bunch of documents, but it really wasn't an Olmsted plan. And so on the 5th anniversary of the Olmsted decision, we're on one more back, yeah. Access Living and Equip for Equality and a bunch of other groups sent a letter to Governor Blagojevich saying, we want to work with you to try to get Illinois to move from an institutional type of society to an integrated one. And we never got a response to our letter. And so what that told us is that we needed to file a lawsuit. In fact, we decided we needed to file 3 lawsuits because I think you can all know is people with disabilities are very siloed in different types of programs based on their disability. We couldn't just bring one class action, so we brought 3 class actions. The ACLU joined us, and I'm going to talk about 2 of those. The one I'm not going to talk about is the one called LIGUS, which is on behalf of people with developmental disabilities, and I was told that wasn't on the agenda today, but you should know in that case, over 6,000 people with developmental disabilities have moved from institutions into the community, and so a lot of effort's been gone on that effort. So, and if people have questions about the LIGUS case, I'm happy to answer them afterwards, but I wanted to respect what was being requested today. So we're going to talk about the other 2. So the first one we're going to talk about is Williams versus Rauner. And Williams versus Rauner is on behalf of people who are in these facilities called institutions for mental disease. How would you like to call that your home? Institution for mental disease. That sound like a homey place? And the acronym for that is IMDs. And anybody live in Uptown or in Edgewater, that area? Okay. You may not know it, but there are IMDs in your neighborhood. That's where a lot of them are located. They're all over the state, but most of them are on the north side of Chicago. And so they're in the neighborhood, but they're very institutional-like. And they're almost 100% of the people who live there have mental illness as their primary diagnosis. And people got stuck there. And so we wanted to bring a lawsuit to address those folks because basically the state wasn't doing anything about those. And they're owned typically by private facilities. And there are about 4,500 people living in those facilities. So we brought that case, and we brought it on behalf. 4 people were our named plaintiffs, and then the court said it's a class action. So then we represented all 4,500 people there. And then in 2010, the case was resolved. We had what's called a consent decree, and what the court agreed was that anybody who lived in an IMD who wanted to leave would be able to leave in the first 5 years. And that the default place for people to go from IMDs is what's called permanent supportive housing. Anybody heard that term before? So permanent supportive housing, if you're not familiar with that term, is basically living in your own apartment with the supports to come in and support you so that you can be successful in the community. There are a variety of services that people can get. You might know of places called Thresholds or Trilogy, which are community mental health providers. They're the organizations that are working with Williams class members in the community for them to get what they need. The other really important thing, especially when Illinois cries poor, is that IMDs are so bad, the feds won't give the state of Illinois 1 penny for those. They said, you got to pay for them 100% out of state money, which makes no sense, right? But when people move in the community, the feds say, yeah, we like that. And they give a lot of supporting and matching dollars. So it actually makes financial sense as well as, philosophical sense for people to live in the community rather than these IMDs. So let me tell you where we are now with the Williams case. One more slide. So in that, we just broke the 2,000 mark in the IMD. So over 2,000 people with disabilities with mental illness have moved out of IMDs into the community, which is exciting. And obviously, what we're wanting to do is to make sure that everybody who wants to move gets a chance to move. And the big barriers we have right now in this are 2 things. One is there's a group of people in IMDs that they call, and I'm putting this in quotes because this isn't my language, they call hard to serve. Okay, and what that means is that these folks need more supports than they currently have available. And so there's some places like Thresholds and Trilogy saying, you know what, this person has a lot of needs, we're happy to support them, but state, we need more money to be able to support them in order to make that happen. Because we don't want to just bring people out of the institution into the community and have them fail or even worse, have some sort of incident or even some sort of accident or some sort of health emergency. And right now the state is having a hard time addressing that issue. So the monitor who's in charge of overseeing compliance has said they're out of compliance because they're not serving these hard to serve people. And so that's something we're working on, because if you do the math, remember I said it resolved in 2010 and they had 5 years? Well, that would mean they should have been done by 2015. Well, it's 2017, right? So that means that they still have a ways to go. The good thing about a consent decree is that they can't be out of it until the judge says that they've met all their obligations. And so they have to keep working on these kinds of things until they meet their obligations. And so it's not like it settles and goes away. The judge stays on top of it, and our judge is very good. So that's one issue. The other issue, if we could go back one more slide, is this issue called shutting the front door. And what that means is that before they can get out of this consent decree, they have to have a plan that not only serves people who are currently there, but doesn't put new people in those IMDs without first giving them a chance to live in a community. Because before, it was like you got to go into an institution to get community services. Well, how stupid is that, right? Why should you have to go into an institution to get community services? Why can't you go straight from needing services right into the community? And so far, the state hasn't figured that one out yet. And so the monitor found them out of compliance on that issue. So until they can figure out the hard to serve and the shutting the front door issue, the Williams case will continue, and more people will hopefully be able to move. All right, so the other case that I know a lot of you know about, and we even have some class members here that I've seen, is the Colbert case. And Colbert is very similar to Williams, except it's a different place and some different types of disabilities. So Colbert involves people who are in traditional nursing homes in Cook County. Williams was the whole state. Colbert is really just focusing on Cook County because of the sheer numbers that are involved. Somewhere around 16,000 people live in Cook County nursing homes. People with disabilities live in Cook County nursing homes. And in Cook County nursing homes, we have two primary types of disabilities. One is, again, people with mental illness, because unlike most states, Illinois puts a lot of people with mental illness in traditional nursing homes. And we also have a lot of people with physical disabilities, including a lot of young people with physical disabilities in nursing homes. Again, very different from other states. And so this case was brought and was turned into a class action. So we went from representing 10 people to 16,000 people. And it was brought, again, by the same groups of organizations along with a private law firm. And that case was approved in 2011. Our agreement was approved in 2011. So let me tell you what's happened with that case. And a lot of the provisions in the agreement are very similar in that the default is permanent supportive housing, meaning living in your own apartment with the supports you need to be successful. Well, in Colbert, which was started a year later, over 1,800 people have moved from nursing homes into the community, which is, again, a really important and good number. Now, obviously, that's just the tip of the iceberg. There's still a lot of people who need to be moved. And the good thing about Colbert is there's not a specific time that they have to stop, because what we built into Colbert, which is an important component because of the large number involved, is a part that's called reasonable pace. Does anybody remember that term, reasonable pace? Well, if you go back to the Olmsted case, the court said that in order to meet your obligations under the ADA, the state has to continue to move people off the waiting list at a reasonable pace. So what we're doing is we're setting up a number of people who move each year, and that establishes our reasonable pace. So even when the consent decree is over, the state will have to continue to move people. It's not like their obligations end. And if they don't continue to move people at a reasonable pace, which is the number we're setting them up with right now, which is probably going to be somewhere between 350 and 500 people a year, if they don't meet that, we can bring another lawsuit. Hopefully we won't have to, but what we've done is we sort of set it up so that we've got some really good evidence of what's reasonable, and if they don't meet it, we can go in. Because the other thing that's really important, and this is just, you know, it's so simple, it's laughable sometimes, is the state is saving, and I remember people said, they often cuss when they're talking. I'm going to use a word. They're saving a shitload of money with the Colbert case, okay? One of the things the state said before we settled the Colbert case is we want to make sure that after the first 1,200 people move, we want to do what's called a cost-neutral plan, just to make sure it's not costing the state more to move people in the community than it is to leave them in the nursing homes. Well, our cost-neutral plan was done, and it showed that the state is saving millions and millions and millions and millions and millions of dollars in the Colbert case by itself. So there's no reason not to continue to move people out of nursing homes except for the evil nursing home lobby, right? And so what we need to continue to do is to push and say, state, it's not only the right thing to do, it's not only the legal thing to do, it's also the most cost-effective thing to do. And so that cost-neutral plan was very, very important. Our problem in Colbert is not about the hard to serve as much or the front door. It's really just moving people fast enough. In Colbert, unfortunately, they've set up this very sort of lot of handoffs, you know. There's not just one organization working on it. There's certain organizations that do the evaluations, and certain organizations that help with the transition, and then certain organizations that help with the support. And it's just very cumbersome. And so the monitor had a whole team of folks go through and evaluate how can we move people faster. And that consultant came up with a lot of great suggestions. And the monitor says, okay, state, this is where you need to do to make sure people move fast enough. And where we are now is that the state is looking at those recommendations and is going to say how they're going to implement those to make it a reality in Illinois. And, you know, I got to tell you, the recommendations are fantastic, but sort of getting from recommendation stage to implementation stage is really can be a tough road. So that's really going to be our next fight over the next year, is making sure they actually do what's been recommended so that people move more quickly. And we recently, our monitor, people may remember Dennis Jones, he's spoken to this group before. He recently retired. But the good news is the person who was in charge of that consultant report, who was really aggressive on the state, she's the new monitor. And you know what? It is good. What was funny is that we had to propose a monitor candidate. The state had to propose her. We proposed her. They proposed an old bureaucrat who never really worked on community integration before, and we couldn't agree, so the judge had to look at it. He looked at a progressive, thoughtful person who'd been involved in Colbert and a state bureaucrat, and he chose the thoughtful consultant. And so she just got appointed last month. They're working out the contract, so she's going to be up and running in December, and I think we're going to have some new fire in Colbert and hopefully keep the state pushing towards these recommendations to make sure folks move. The last thing I just wanted to say, and then I'll open up for any questions that people have, is just to remind you that why consent decrees are so important. You know, we've been without a budget in Illinois. We went without a budget for 2 budget cycles. Remember all that? How horrible that was? It was horrible for people with disabilities, and you know, a lot of people suffered as a result of the state's inability to get its act together with regard to the budget. The good news for the Colbert and the Williams case and the Liggis case is that we had a consent decree. So even though the state was saying, you know, we don't have a budget, that wasn't an excuse, and they had to continue funding. So those numbers didn't stop during the budget impasse. And so that's why it's so important whenever you bring these kinds of actions that you get what's called a consent decree so that the court stays involved and the case isn't going to be suspended or the relief isn't going to stop just because the state says it's poor and doesn't have money, because the state always has money. It's just a matter of how they spend it, right? And so the judge granted both of those motions in the 2 years that we had the budget impasse, and the payments allowed class members to continue to move throughout the process. So that's just something I wanted to make sure people were aware of, that the Colbert and Williams cases continued despite the budget impasse that was involved. So Tom, I'm happy to take questions, but if you guys need a break, you just let me know.
Someone earlier, living in a nursing facility, using their wheelchair, okay? And she was told that she could not get a wheelchair because she's in the nursing facility. But the nursing facility is not going to buy her a wheelchair. I thought that was already settled, that they're supposed to buy them a wheelchair. Please tell me what's going on.
We've handled those cases before in helping people get assistive technology within the nursing homes. It's not covered by Colbert, but it's something we can take a look at, so people can give us a call if they want. Okay. Or if that person's here, I'm happy to talk to you afterwards.
Thank you, Barry.
Sure.
My name is Edwin Berry, and I wanted to ask about IMDs. Is that the same situation as persons that are in nursing homes where they keep their check and give them an allowance of $30? And are those people, is there an agency that helps them when they do want to move into the community with security, deposits, and rent?
Yeah, so IMDs are nursing homes, but the difference between them and a traditional nursing home is that at least 50% of the people, it's usually about 100%, have as their primary diagnosis mental illness. And the money you're talking about, the personal needs allowance, applies to IMDs and to traditional nursing homes. The good news is that personal needs allowance recently was increased by the legislature, so it's more than $30 than it was before. The bad news is that it hasn't been implemented yet, at least last time I heard. I don't know, Tom, if that's changed. Yeah, so there's been sort of an administrative snafu on moving that more quickly, but it's going to happen as you go. When people move into the community, they would get some rental assistance that would help them with the transition period, and that would cover some of the security deposit issues that you're talking about, as well as some of the transition costs that are necessary.
Yeah, and Barry, the $30 was for IMDs, but not for traditional nursing homes.
Great, thanks for clarifying that, Tom.
I want to ask with all this stuff with the home care stuff, PA hour, was that for anything?
I'm sorry, I'm having a hard time understanding.
I think with all this surgery messing going on with the home care stuff, was that violate the laws?
You know, the state's just been making it harder to be to manage your own PA.
Right, you're making a great point. So the Olmsted case generally applies to people who are in institutions, but it's also been applied to people who are living in the community who are at risk of institutionalization, meaning that if the state doesn't provide the supports necessary, the person's only choice would be go to a nursing home. Now, Williams and Colbert only apply to people in institutions. The Liggis case that I mentioned applies to people at risk of institutionalization as well as actual institution, because we have such a large waiting list of people living at home. But we have brought cases in the past on behalf of people who are at risk of institutionalization when the state has cut services. That's my, with the overtime, at this point, we don't have enough evidence showing that people are at risk of institutionalization, but it's something we're carefully watching. And we do a lot of representation of individuals whose home services have been cut. And so we've been just getting a ton of those kinds of cases. Unfortunately, there aren't a lot of organizations taking those, so we've been taking most of them in Chicago. And in most of the cases, we're able to get those services or those hours restored. So if people are getting cuts, maybe getting a redetermination and saying you're no longer needing a certain number of hours, please contact us because we've been working on those cases pretty regularly and can help you. The overtime issue is more of a let's wait and see kind of situation as to what impact it's going to have on people. There have been some adjustments to those hours, and people are saying, need to see if that's going to be enough or not in the adjustments.
Barry, a big part of the Colbert problem is the MCOs. They are one of the gatekeepers. They're the middle person. They have a lot to say whether you go in the community or whether you don't.
Right.
How do we forcefully at some point get around that? Because that's an issue for people that want to get involved with the Colbert consent decree.
Right. So in case people aren't aware of that acronym MCOs, that stands for Managed Care Organizations. And, Illinois moved to a managed care for people in nursing homes a number of years ago, right actually as Colbert was being implemented. And the state decided that they would use MCOs as opposed to other groups to do the evaluations. We thought that was a terrible idea, and we said so, but the judge said that they could give it a try. They gave it a try, and it didn't work out very well. And the monitor found them out of compliance, saying that their evaluations were really terrible. And so the monitor's been working closely with the MCOs to make the evaluations better. They've also identified other groups. So now on the mental health side, Trilogy and Thresholds are doing the evaluations instead of the MCOs. So that's helped a lot. The MCOs are still doing most of the evaluations for people with physical disabilities. They tried a couple of alternatives that didn't work. So it's a work in progress. It's gotten better. It's still some real problems. But the fact that they're not doing all the evaluations, I think, is an important step in the right direction.
Okay. Hi,
Yeah.
my name is Lindsay. I'm a current Colbert member. What I have found in this more than 2-year rigmarole that I've been going through is that it's not just Trilogy doing the evaluations, it's also the MCO, and that is something that you just mentioned. But I've also found that I have my cousin who was also in a nursing home. She was misevaluated upon leaving and now cannot get reevaluated for home care services. It seems like it's impossible, and nobody seems to be able to help her get evaluations.
Yeah, so we're happy to talk to her directly about the situation she's gotten. When we have individual calls from class members, we raise that with DOA and have worked on those kinds of issues. So I can talk to you directly afterwards about my contact information so that we can talk to her.
I would appreciate that.
Sure.
Thank you.
Thanks very much for your attention.
Yeah, let's give Barry a hand. That was a wonderful report. Thank you. Okay. We're going to move right along. I think Joy is going to kind of skip her ranking of Illinois, but I'm going to put her on just to...
Just to let you guys know, I am inviting you. We have a national study going on right now of doing interviews with people who are getting out of nursing homes and into the community. I was going to present some of the results today, but I can tell you want your food and you're tired. So I'll come back and do that at another time. But we are looking for people to interview right now, and we're able to pay people for doing that. So if you have folks who have gotten out of the nursing home within the last 5 years or an IMD, and they're willing to share their experiences with us, we're trying to document it nationally as part of a national project right now. And I can tell you guys, your outcomes are looking incredibly good for you here in Chicago and Cook County on what the results are of being able to transition out. Very compelling that we want to give more of these to the state of Illinois. So please refer people through Tom. He can get you into us, and we can get you involved in our interviews. And with that, I'm going to pass it over to Tom.
Yes. Now, we're going to talk about next steps or advocacy steps. You've heard a lot of information today. Some of it's about problems, some of it's about solutions. But one of the things I think that I would look at is we had the sheets of paper which showed that people want more information for self-advocacy. And I think self-advocacy is a great thing, but the problems are often systemic. Am I right? Like when I hear PACE talk about people with a problem, they always treat it as an individual problem. Even though maybe 100 people had the same problem that day, they treat it as an individual problem because they don't want to change their system, right? So it is up to us to be the voice and the force that makes those kind of changes, the systemic changes. And Jasmine says we're always the voice of change, but we're more effective at it if we're together and organized, and that's something I'm going to talk about. Access Living has taken advocacy pretty seriously over the years. We've done advocacy around home care issues, around housing, transportation, durable medical equipment, getting people out of nursing homes. Access Living was part of the Colbert and Williams cases, and for access in the community. One of the things that Access Living, I think, has done right is it's organized consumers to be their own voice, to speak up. It's not some advocate that's sitting there trying to negotiate for people that don't know what's going on, right? We need to stay away from that model, I think, as much as possible. We know that people with disabilities still face isolation, sometimes low expectations, exclusion, discrimination, and way too much poverty. And so there's still a lot to advocate around. And most recently, we've been taking on the state on the overtime issue. That one has been a hard nut to crack, but we're not going away. And we also involve consumers. I don't know, many of you get, I think, the email flashes where you could do calls to talk about saving the Affordable Care Act from destruction where it would hurt Medicaid and wipe out $1 billion in funding for Medicaid. And right now, we're right in the middle of a battle around trying to improve paratransit. The other thing I wanted to mention is that Access Living is building from its advocacy in various issue areas into bigger campaigns around the Power to the People group. And one of the things I think that we're going to be taking up in a bigger way, many of you know Candace Coleman. She's on vacation this week. But she wants to help organize around racial justice issues and is going to be introducing a bill in the legislature called Stefan's Law, which would help improve the situation for people who have psychiatric or autistic or other mental or cognitive issues, so that the police don't shoot them before they get a chance to get services and help in a hospital setting. I have a question for you. Does the disability community need more power? Yes. Okay. And what is power? Is it control? People power. Okay, it is about people. And is it control over your own life, a say in what is going to happen? Yes. Okay. And so what do we need to do? I'm just going to point out we need to organize, and organize, right? Organized power is a lot more effective than unorganized power. So one of the things that I want to encourage you all is to actively participate in the groups, to actively participate in Power to the People. And we're going to have Mike talk about ADAPT, which, you know, ADAPT is probably the most powerful disability organization in the whole country, and he can tell you more about that. I just want to add a couple more things. You know, the groups that, when we organize people with disabilities, they need to be led by people with disabilities, right? They need to be people who have the lived experience of that disability. And we need democratic structures so that people are all involved in the decision making. We need to find allies, but allies who take us seriously and make accommodations and access an important consideration. And then we also need to develop leaders. And I think of all of you as leaders, but we can all improve in our skills in using social media, in ways to develop and make more powerful protests. And we need to always be recruiting new people, because new activists are the lifeblood of any movement, I think. So with that, I'm going to bring Mike in. I'm going to go to him, actually, and he's going to talk about organizing as well.
Hey, everybody. Sorry, I'm the last thing standing between you and your tacos, but I promise I will make it quick. Yeah, I just wanted to talk just a little bit about ADAPT. And if you look around the room, you can see lots of pictures of people blocking buses and marching and blocking doors and things like that, culminating in the signing of the ADA over there. And almost all those pictures are ADAPT actions. I'm in the one right behind me. You can't really tell. You can see my foot, but that's about it. If you kind of look closely at some point, you might see my foot. That's blocking the door of the Healthcare Financing Authority many years ago. And for some reason, the cops said, all right, if you guys don't leave, we're going to bring in those cops standing sentry in front of us. And they river danced in. It was really weird. It was like river dancing. And they stood in front of us and scowled at us for 5 minutes. And then they river danced back out, and that was it. And I don't know, that was supposed to scare us, I guess. But at any rate, ADAPT started in 1983 in Denver, and the issue was public transportation. At the time in Chicago, imagine if there was no CTA at all. Imagine if the CTA shut down tomorrow. How would you get around? Well, that's what it was like in the 1980s if you had a wheelchair, if you used a wheelchair, had any kind of mobility disability, and couldn't climb the steps of the bus. There were zero accessible buses in Chicago in the 1980s. So basically, it was like there was no CTA. Try living a life that has any quality at all, and you don't have a car if you don't have any public transit. So ADAPT joined the national group, took that on, used what we call the pitchfork approach, which is basically do anything that works. We did street protests, we did a lawsuit. There's some people here like Drew who were involved in that lawsuit, and we ended up winning that lawsuit. And eventually, because we did street protests, that got a lot of attention to a lawsuit that otherwise might not have gotten much attention, and that helped to put it over the top. And today, transportation in Chicago, the buses are 100% accessible, and trains are about 70% accessible. But the ADA says no more. Anytime you order something, it has to be accessible. From then, ADAPT moved on to the issue of living in the community. And what does it take to live in the community? What does it take to get out of a nursing home? People who end up in nursing homes usually have the least of everything, the least money, the least support, and they need the most help from the community, beyond family. So what does it take? It takes programs like the things that you've heard today, where people get financial support to get out of nursing homes and stay out of nursing homes. It takes getting in the faces of politicians so that they change policies that favor the people who fund their campaigns who own nursing homes. It takes all that kind of work. It may not seem sometimes that we're getting somewhere, but as Bob Kafka, a organizer for ADAPT, says, it's like turning the Queen Mary. And by that, what he means is, if you're on a big ship like the Queen Mary, you may not feel that it's turned around, but suddenly you look and you're facing in another direction. And the money that was spent on institutions 30 years ago has shifted, I believe. Do you know the numbers on that?
Well, when I started here, it was about 80-20 towards the institutions, and now it's at least 55% in the community, 45, I think, in institutions.
So billions of dollars have shifted away from institutions and in the community. Unfortunately, it's not enough, and that's why we keep going. But what makes ADAPT different is that we get in faces. We look for who we call the yes-no person. And the yes-no person is the person who can make the decision to do what you want. It's not a secretary, it's not a chief of staff, it's not a PR person, it's the governor, it's the mayor, it's the president, it's whomever. And we fight and we protest peacefully, of course, aggressively but peacefully, until we do get in that person's face. ADAPT has been able to get a meeting with every governor, including Rauner, since all the way back to Jim Thompson. And we've been able to, we feel, keep the home services program and other programs growing and staying strong with help from others like SEIU and such. Right now, our most important issues are the overtime issue, trying to keep that from being implemented. We have had some success because Susan and others joined in on a lawsuit. We're able to hold it up for about 9 months and get a few changes made so that it's not quite as repressive as it was, but we're still fighting to get that turned around. We also want to make sure that our workers are paid well and treated well, and that they get raises periodically, and we work on those things too. The reason why I like ADAPT is because I don't like to lose. I don't like to play games and lose. When I play a game, I like to win, and ADAPT wins. And that's why I think the reason they win is because they get in the face of the people in charge. The people in charge quite often know that they're doing something wrong, and they don't want to admit it. They want to hide. They want to be in a corner. And if you force them to come out of that corner, you start to see real change on big issues. Getting people out of nursing homes and keeping them there is the most important thing, I believe, that we can do. And it takes a lot. It takes a lot of the kinds of things that we've talked about today. So if you care to join us, we meet every first Wednesday of every month at 5:30 here at Access Living. Unfortunately, our meetings are a lot of business, a lot of acronyms flying around. So unfortunately, they're sometimes not the most stimulating thing in the world, but they are necessary, and we do welcome everybody, and we try to make you feel at home, and we try to create other opportunities where we can all get together, because you know what, it feels good. It feels really good when you win. When you get in their face and you make a change, that's about the best feeling you can have, and that's a whole lot of fun. So hope you join us and have some fun. Thanks a lot.
Let's give Mike a hand. That ends our agenda, but I do want to throw out a chant. Is Chewy here anywhere? Chewy. I think we could do, how do you spell power, right? Chewy, do you want to do that one? How do we spell power?
How do you spell power? Oh, yeah, I can't hear you guys. How do you spell power? A-D-A-P-T. How do you spell power? A-D-A-P-T. All right. How do you spell power? A-D-A-P-T. Thank you.